Welcome, I'm board-certified emergency physician Dr. Liane Stanton. We have a special episode of the StantonMD show. Today, we're talking all about heroin and the opioid crisis. The opioid crisis has exploded over the last 10 to 15 years, starting with prescription pills and now progressing to stronger and stronger doses and instances of heroin. Thousands are dying across the country, with the Appalachian region being ground zero for the addiction and overdoses. Over the next 30 minutes, we're going to visit with law enforcement, EMS, addicts, and health professionals as we try to work forward and move to a cure to the epidemic of opioids in America. It wasn't until she was prescribed Percocet for persistent migraines that her downward spiral began.
It was a Percocet prescription intended just to treat headaches as needed, and I think the prescription, and I guess it may be weird that I know this, but it was supposed to be taken one every 6 hours as needed. And that prescription should have lasted me a week, if not longer, and it lasted me 2 days. It spun out of control so quickly I could never get a hold of it. Disease of addiction is so cunning and baffling that it comes at you in every form, wrapped up in the best packages, and it almost sneaks in when you least expect it.
As her addiction grew and grew, Liane faced the challenges of a growing dependence and increasing need for drugs. She became desperate. She began using her nursing license and job to fill prescriptions at pharmacies around the city. She told me that she would clean up, dress as nice as possible, and go into those pharmacies with falsified prescriptions in order to get what she needed. But eventually the law caught up. She remembered hearing rumors that the police were looking for her, but she never truly believed it until the police knocked on her door.
All of my criminal charges spurred from me filling prescriptions that were not in my name, or were not to me, and filling prescriptions fraudulently.
She also notes that jail is not the answer to the addiction crisis.
There was nothing about jail that taught me anything other than that I didn't want to go back there, and how to become a better criminal, how to hide things better, how not to go back, and not how to get clean.
As Liane recovered, she found that one of the gifts of her addiction and subsequent recovery is that she can help others navigate the same path. She talks about the challenge of sobriety. She also has a message for others who are fighting addiction.
The obstacles that are placed in front of you, day one, going back to just for today, there's still a possibility to recover. Recovery is possible. Placing the right things and the right people in your path is very crucial to recovery. Maybe a message is get clean whichever way works for you, because recovery will work as long as you work the program.
And we'll come back to Liane's story here in just a little bit in the broadcast, but definitely a sobering story that plays out throughout our region and nation. We are currently in the worst drug addiction epidemic in the U.S. history. It's to the point that it has basically flattened out the graph of prior drug spikes, and medical professionals believe it all started with this: a misuse and oversimplification of a 5-sentence letter to the editor in a 1980 publication of the New England Journal of Medicine. This single document has been used to market prescription opioids as low risk and potentially addiction-free. We now know that this couldn't be further from the truth, but now we are trying to deal with the downstream effects, which has produced millions of addicts and is killing tens of thousands every single year. The greatest misconception of drug addiction is that it's a choice. There was a choice in the beginning, but the dangers of these drugs and many others is that they reformat the brain. Much like a computer, the brain's wiring tells us what we need, what to do, and when we need to do it. Opioids impact the reward center of the brain, basically rewiring it to the point that research shows it will trump every basic need we typically experience, including eating, hygiene, and caring for family. A doctor who became addicted to prescription pain medications once told me, "Every one of us would take a bullet for our children, but these drugs made me forget my children." The problem we had is that we experienced the perfect storm of ingredients to get us where we are today. In medicine, misconstrued research and bad data led to the impression that risk of addiction was low, coupled with a change in concept that every person they deserve to be pain-free, which was bolstered by satisfaction surveys and regulatory agencies that focused on pain management, encouraging liberal use of powerful medications. Also, economic hardships, especially in the Appalachian region with the loss of coal and factory jobs, led to an economic coping strategy in which opioids were used as a way to produce an income, with pills bringing in $1 per milligram. Profiteering clinics and pharmacies, pill mills, were happy to supply these growing demands, with some doctors responsible for millions of pills prescribed in a single year. Then, evolution of the heroin industry flooded middle America with cheap and potent heroin to replace pills as addicts' tolerance skyrocketed and the cost of their addiction turned them to cheaper yet more powerful options. Over time, other drugs were added to the heroin, including drugs like fentanyl, ketamine, methadone, and others. We're now seeing substances on the street that can overdose with minute quantities and even through a simple exposure, like the recent Ohio overdose of a police officer when he was exposed to a drug while making an arrest. What this has produced is an explosion in overdose deaths, easily surpassing the annual deaths from car accidents. But it's not just the deaths. We are seeing spikes in infectious diseases such as hepatitis B and C, HIV, skin infections, and endocarditis throughout hospitals and emergency rooms. Also, the destruction of families, orphaned children, and disrupted communities. As an emergency physician, I've had a front row seat witnessing death, pulling lifeless bodies from cars, and seeing the hurt and loss. Now we have two challenges: preventing the creation of future addicts and providing the resources to help current addicts recover. There is finally a shift in medicine to focus on evidence-based and safer methods of pain management. This takes time, but will hopefully impact the number of new addicts in our communities. Also, laws and government agencies are evolving, with efforts focusing on prescribing, recovery, and drug supply. Unfortunately, if we don't provide adequate recovery resources, even the most drug policies, most robust ones, all they're going to do is change the substances that we're seeing that are abused. Our goal this hour is to turn on the lights, pull back the curtains on this epidemic that is pervasive throughout our communities. We will talk with those that are leading the charge, from law enforcement to healthcare, policymakers to those helping save lives. Through education and facts, maybe we, as a community, can come together and help repair some of the mistakes and challenges of the last 20 years.
You are watching a special edition of ABC 36 News, Kentucky's State of Addiction, the Opioid Crisis. This epidemic has led to countless overdoses. In many cases, the determination of whether somebody dies or lives comes down to minutes.
That's correct. EMS services around the country are that life-saving immediate response. You quickly realize the growing impact when you sit down with these men and women on the front lines of medicine. Lexington Fire and EMS is no stranger to overdoses, but over the past few years, the numbers of heroin overdoses have skyrocketed. Whereas overdose deaths within Kentucky could be counted on your hands 10 years ago, now the annual death toll is in the hundreds and climbing. But this is just the tip of the iceberg. For every death, there are dozens of overdoses that require assistance to prevent another life lost. That assistance comes in the form of a reversal drug known as naloxone or Narcan. As of 2010, Lexington Fire was administering about 500 doses annually, or about 42 doses a month. Paramedic Justin Teetry tells us that's not the case anymore.
On average, 149 a month throughout the entire year. That's what we're looking at through the year.
Not only are the number of doses going up, but the amount required to save a life is rising as well.
Here lately, we've been noticing that it's taken more doses of Narcan. Now that's not every case, but it's taken more doses of Narcan to wake these patients up.
Battalion Chief Brian Wood agrees.
A lot of the heroin's a lot stronger. It's being cut with fentanyl, so it's taking the normal patients to take one dose to wake up. Now we're seeing patients that it's taking 2 to 3 doses, and then even when we get them to the ER, they're having to put them on drips and administer even more.
One day we can have, on this truck alone, we can have no overdose runs. We don't administer a single thing of Narcan. The next shift we can have 5 or 6. I don't know if that's a trend of a pattern of when the drugs are coming in or the distributors are giving them out to the people. It just really all depends on the day and the situation when it comes in. I do know that when there's one, more than likely you're going to have an influx of it. So if there's 1 or 2 out in the city, it's probably been a bad batch. You're probably going to get 3, 4, 5 more that day.
In the end, it's about saving lives, and both Wood and Teetry report they will do everything possible to ensure they are there when needed.
We don't get to you within 5 or 6 minutes, you're probably not going to have a good outcome, being as you're probably going to be dead.
More Stanton MD coming up. Stay with us.
Do you own or work for a business that advances health and safety of the public or its employees? Then you may be interested in becoming a sponsor of StantonMD. There are various opportunities for sponsorship, from the show to the website, social media, print, or a combination. For more information on becoming part of StantonMD, contact Jen at info@StantonMD.com. That's info@StantonMD.com. Now, back to the show.
Welcome in, everyone. I'm Tom Kenny.
And I'm Dr. Liane Stanton. We continue with our special Kentucky State of Addiction, the opioid epidemic. Our goal is to help pull back that curtain, turn on the lights on the worst drug epidemic in U.S. history. With knowledge and understanding, we can advance the path of recovery and future prevention.
And one of the greatest challenges in understanding addiction is that it may start with a choice, but quickly takes over the brain and eventually takes over your life.
And that's exactly what we learned from Liane Story. As she realized her addiction was stealing her life, going from a hidden habit to a downward spiral and tightening grip of addiction and substance. As addiction progresses, the addict pulls farther and farther from family and friends in an attempt to conceal the problem. Unfortunately, this does not protect these people from the ongoing decline. In addiction, relationships are strained and many are destroyed at the hands of illicit substances such as opioids.
No one truly knew what I was doing. Nothing had come out at that point. So I'd hidden it really, really well.
The first step to recovery is admitting there's a problem. Many addicts get to this point, but this by no means is the hardest part. The grip of addiction on our minds and bodies is difficult to break. As addicts attempt to break the grasp of the substance, the body and the substance fight back with withdrawal symptoms that can make recovery seem impossible.
Those were the most miserable days of my life. And if any addict would tell you, and if anyone would ever experience withdrawal, they would never tell someone, why can't you just quit?
Recovery is a lifelong commitment. Once addicted, the brain is always addicted, meaning that the person is one decision away from relapse. Liane understands that every day is a gift and that she must commit to a sober life on a daily basis.
Because when you start this program out, when you start on the journey to recovery, it's a minute at a time, maybe 5 minutes at a time, an hour at a time, 4 hours at a time. You take it that way because honestly, sometimes that's all you have.
Even though family and friends want someone to be sober and it can seem very difficult at times, it won't happen until the addict makes the decision to start the journey to recovery.
Don't give up on your loved one, as hard as it is, and I know the active enabling is very easy to do because I did that with her, with Liane. I gave her money for her bills and things at the time when I didn't know it was for drugs, and even when I think I maybe assumed it was, I still wanted to help.
I'm so proud of the journey she's taken just to get control back of her life because that adds so much trust in our relationship.
Liane knows that there are millions out there right now battling addiction and that she has a message that can only come from someone that has walked the path of addiction and recovery.
The obstacles that are placed in front of you, day one, going back to just for today, there's still a possibility to recover. Recovery is possible. Placing the right things and the right people in your path is very crucial to recovery.
Certainly an incredible story of addiction, of loss, and recovery. Our thank you to Dr. Stanton for that. I'm joined now by Dr. Dinesh Maslimdoost. He's an anesthesiologist and pain management specialist from Wellward Regenerative Medicine. Doctor, how do we better address acute and chronic pain?
So I think it's really important to understand what is pain. It's the way our body communicates damage to us. And it's a matter of understanding what we need to do to fix it. It's not as easy as just throwing a medication at it and being done with it. We know that the risk of dependency spikes after only 3 days of use, so figuring out other ways to address pain without relying on opioids and keeping people away from that risk.
So what alternatives do we have if we don't go the opioid route?
There's a lot. There's been major advancements in regenerative medicine where we can actually stimulate or essentially hack into the body and help it heal better. Exercise is a great way, and that's why physical therapy is always a first line, because the body really does heal itself, and it's a matter of better understanding what the origin of pain is and then figuring out what needs to be done to strengthen it and make it better.
Was there a time in medicine where the first choice was always the prescription painkiller, and are we getting away from that?
Absolutely. There was a time where the first-line agent to treat pain was an opioid, and it was misinformation that was just propagated based off of really bad studies. Now we know that the risks are incredible, and we're seeing the epidemic very evidently. So the whole infrastructure of medicine is starting to change and re-examine how we do things.
And as you know, that research was well intended and it was in credible journals, but it was still bad data. And we're still paying the price for that today, aren't we?
Absolutely. I mean, the intention was to treat pain because pain is relatively undertreated across the world, but this was not the solution. It was really to get a better understanding of how do we treat pain in a holistic and sustainable manner, and opioids were not the solution.
I know that you look at numbers, you see them come across your desk in your profession. What are those numbers telling you where we are today?
It's staggering. I mean, since 1999 to now, we've lost the equivalent of Lexington, Frankfurt, and Georgetown combined in terms of people who've passed away from an overdose. We know that after every surgery, 6% of those patients, every single surgery, doesn't matter if it's a heart replacement or a hernia surgery, 6% of those people will become dependent on opioids. That's the highest complication rate for any surgery for any condition.
Right, and as you said, that could be a simple, benign outpatient procedure, and 6% of them are going to end up addicted.
Absolutely.
Doctor, thank you so much for your expertise and your insight. As promised, our panel of experts here to answer some of the questions that have been sent to us on Twitter, and we want to thank everybody who has tweeted in this evening. We do appreciate that so much. And let's begin with viewer Brian McDowell, who asks, are there areas of the country that have successfully overcome the opioid epidemic? And if so, what was effective? What can be done here in Kentucky? Dr. Stanton, as you reintroduce our guests.
All right, so I'm going to introduce this one to Van Ingram. He's the Executive Director for the Kentucky Office of Drug Control Policy. And we actually saw this question coming up, and we talked about it a little bit in terms of where Kentucky is standing on this issue.
Yeah, I wish there's somebody who had figured the opioid crisis out and we could follow what they're doing. Unfortunately, as you mentioned in the earlier piece, we were really ground zero. Kentucky, West Virginia, Appalachia was really ground zero for this epidemic. We've had it longer, and we've put more things in place that other states have followed. Kentucky's really been a leader in drug policy for the last decade as it relates to this problem. Every now and then a new idea comes out that we can borrow or steal, but for the most part, we've been right at the forefront of everything that's been done in this country.
So, Lieutenant Harris, we kind of hit on it a little bit earlier about, we heard Liane talk about incarceration, how it didn't help her recovery, and then the questions we had earlier. Are there better resources that are out there other than putting these folks behind bars?
Well, our focus in investigations and enforcement is always, or is most often, traffickers. Those are the people that we're looking for. We're not looking to arrest the everyday user, and that's not to say people don't get charged with possession, because they do, but our focus, our police department has made a major commitment to assigning investigators to hunt down and arrest traffickers of heroin specifically.
And Jesse, make that note again too. You said when officers show up to a scene, they may see illegal drugs on the ground, but they can't make an arrest.
Right, that's actually in statute now. If there's a report of a heroin overdose and our officers respond to it, even though there may be evidence of that crime there, the heroin, we wouldn't charge a person there. Again, we're going to try to make referrals. We're going to try to ensure their safety first, calling the fire department, that sort of thing, and then once we've ensured their safety, then we're going to make it referrals for services and that sort of thing, and then try to follow up from there, do further investigation to see if we can get information from them about where they're getting their illegal drugs from. But that's going to be our focus.
And that's important because we want folks to seek help for somebody that overdoses and not wait. We're talking about minutes from an overdose to death, and if people are worrying about law enforcement coming in and throwing them all in jail, we're likely not going to get that 911 call that can save somebody's life. And they may go back to abusing, but eventually we're going to be able to get them and get them recovered.
Let's take a look at another question that has come in via Twitter, and again, thanks to everybody who's done so. Dr. Howie Mel asks, how is heroin used? Are the effects, the dosages, etc., different between routes of administration?
Well, from our experience, it's either smoked or injected is the most common form that we would encounter on the street. Heroin injection seems to be faster. You get a faster dose of that, a better dose by injection.
You know, when Operation Unite started their treatment hotline in the 5th Congressional District in 2004, about 1 in 10 users used intravenously. Today, that number's 10 in 10 that call are using drugs that way. Because, you know, as you know, Dr. Stanton, after a while, the oral taking doesn't give the same rush or euphoria that the user is used to. Next thing is snorting. The next thing is injecting, always trying to regain that euphoria that we got that first time. It's unfortunate, but we have the fastest growing rates of hepatitis C in the nation here in Kentucky because of that rapid increase in IV drug use. So that's why you see the General Assembly pass a few years ago, if communities want to have a needle exchange program, they can, trying to reduce that exposure and reduce the number of needles that are on the street and that type of thing.
And that needle exchange program, for example, right here in Fayette County has proven to be very successful. Gentlemen, thank you so much, and thank you for your questions on Twitter. We'll have more in a moment. Back now with our second panel of experts to hear your questions that you sent to us today on Twitter. And again, thanks to everyone. Dr. Dinesh Maslim-Doost is here along with Shane Bell from Bell Recovery Centers, who you heard from earlier in our broadcast. Gentlemen, thank you. And let's go to our first question from Twitter. It comes to us from Amanda Dock, who asks, what percentage of first-time users become addicts? Can you compare the death rates from overdose over the last 20 years and why the increase? So we get a couple of questions in there.
So I can speak on that. The risks of opioid dependency spike after only 3 days of use. And we know that in studies show that 30% of users who've been prescribed an opioid for over 31 days end up using opioids a year out from the time they were prescribed. So nobody's immune to this problem. It's a pretty widespread issue. I mean, the parts of your brain that respond to opioids, you're producing opioids in your brain all the time. It's just a matter of if you get a boost from an outside source, it's very likely that you're going to become dependent to it after a certain period of time.
And Shane, what do you see from the recovery side of it?
You know, we've heard things, several different articles and people that I've spoken with that say, you know, from 5% to as high as 20% of first-time users. But honestly, it's so individualistic that it's really hard to pinpoint a number. I think people are so concerned with these numbers that, you know, whoever's doing the study or whatever the audience is, they can skew the numbers ever how they like. You know, the human brain does what? I mean, it seeks pleasure and avoids pain, right? So, of course, you're going to have those people that are going to be more susceptible if they're just out partying and a friend comes over and they decide to try a drug. In that scenario, they may become addicted. But typically, like Dinesh was saying, it does take some time for the patient to become addicted after several weeks of ingesting the drug.
Because we do hear all the time that there are some drugs out there now that if you do them one time,
yeah, you're
an addict. Is that hyperbole or is it true?
In my experience, I think that's probably myth. I'm not sure that we've ever come across anything over the last 10 years that has been out to where after the very first usage, you just become this addict. Have you seen something different?
I would agree. I think it takes multiple exposures, but we also have to be careful about terminology. Addiction is different than physical dependency, and you can become dependent very quickly, but you may not be addicted. They're a little bit different.
And it's very difficult to know. I mean, and we've talked about it before, is being able to know who is most at risk for a shorter term to addiction to dependence versus those that can easily set it down. And that's very difficult and honestly a Russian roulette that I'm not really willing to pay.
Yeah.
This next question comes from viewer Shayna Campbell, and it's for heroin users. So you've been at rock bottom for a while now, jail, rehabilitation, you lost your job, the kids taken away, etc. Why do you keep going back to this life? What is keeping you from seeking help instead of your next fix?
And we saw, and I touched on this in that introduction, and this is the rewiring of the brain. Physically, your brain telling you that this is what you have to have. In fact, there's been some studies with rat model studies, the one that we saw very early in this, that they basically would starve to death to get more of this drug, getting away with food and water, and it's many times the same way. It's rewiring.
Yeah, and I always tell patients, despite what your teenagers will tell you, their brain is not fully developed until they're in their 20s. So the younger you are that you get that first exposure, the more likely you are to become dependent. The other element to this is that much of addiction is just premised in how people cope. And if you've never learned how to cope with difficult challenges, it's very easy to find some external source like a drug that helps cope with different difficulties.
And I want to make sure that we get this, since we have your clinic, that one of the questions that came from Stephen Anderson, he sent a question is, should EDs be writing buprenorphine at discharge? And that gets into the question of some people are so far up this pattern of addiction that we can't just cut them off cold turkey and say, hope everything turns out right. Talk a little bit more about the medication that we're using.
Absolutely. Our physicians are trained to write basically 3 FDA-approved buprenorphine and naloxone formulations. Whenever the patient leaves our clinic, although they're going to be involved in group counseling, individual counseling, we're going to try to get them involved back into the community so that they can be fully functioning once again. There's always that chance that a patient may indeed use this type of medication to bridge. Are you familiar with that term? If the general public isn't, it's where the patient basically uses the buprenorphine naloxone formulation whenever they're starting to go through withdrawals. They're either taking the heroin or the other opioids out there, the OxyContin, hydrocodone, and then when they run out of that medication, then they use the buprenorphine naloxone combination to not go through withdrawals or experience withdrawal symptoms until they are able to make it back to the physician.
Right. All right, gentlemen, thank you very much. And again, thank you for all your questions on Twitter. We'll be back in a moment.
That wraps it up for this edition of Stanton MD. I appreciate you tuning in. Only through education and the efforts of all of our communities can we help dig out of the worst drug epidemic crisis in U.S. history. I invite you to check us out online, StantonMD.com. Also, join the conversation on Facebook on the Stanton MD page at EverydayMed. Also, at EverydayMed on Twitter. And you can email me, youreverydaymedicine@gmail.com. I'm Dr. Ryan Stanton, and this has been Stanton MD.